Good morning. Yeah. The first question I pose is, what does it mean to be born in India today? Probably it means to be a part of one of the largest economies by the 40th birthday. It means something else. It also means to be exposed to the greatest risk of not even making it to the 5th birthday. The point that I'm trying to make is India tops the list in the infant mortality and maternal mortality worldwide. The United Nations has set the Millennium Development Goals, 3 out of which relate directly to health. To reduce infant mortality and maternal mortality are watchwords worldwide. Where does India stand? If that red arrow would show the Millennium Development Goal requirement, as usual, we have never caught up. How does this manifest into? An infant mortality as high as 56, in some pockets it is 76, which is in par with sub-Saharan countries. The Millennium Development Target for India is 27, and at this rate, I'm afraid if we can really catch it up. The point is India an economic powerhouse or a health weakling? Here is in order to investigate as to why it is such in India, let us see two sets of statistics. The first set. 2 out of every 3 Indians do not have access to specialist health care. 1 out of every 3 Indians has to travel more than 30 kilometers for basic health services. When we say India lives in its villages, we just have 0.6 doctors for 1,000 villages in India. Point. We really do not have skilled manpower. The second set of statistics. Here is an interesting list. Kindly look at it. I have taken it from the Millennium Development Goals report of the United Nations 2007. Any guesses? These 7 countries? Any guesses? These are the world's poorest countries. Now to this list, I add one more country. Yes, India. And these are the only 8 countries in the world which spend less than 1% of GDP on public health. Second point, we really got no money. Having said that, what do we have to do next? Back in 1970s, the government set a Srivastava committee which realized that we got to topple down the health pyramid, wherein the community comes to top. We need to give people's health in people's hands. What was done was we asked postmen, we asked teachers to deliver health to people. But it of course did not work. You know, if I ask you to give a medicine to a patient, and if the patient happens to be a relative, how much you can do? Now, in order to solve that problem, government introduced a new thing. Now, in order to know that, we really need to understand how the health delivery system in India works. There's a district. Under a district, there will be blocks. Each block contains some PHCs. Now, each PHC has sub-centers. In a sub-center, you will have a health worker male and a health worker female. Now, these 2 people got to serve a population of 8,000. So, basically, the ratio of the healthcare provider is to the health seekers is 1:4,000. Now, in order to reduce that ratio, government introduced these new people, this new group of people who we call ASHAs, accredited social health activists. An ASHA is a community volunteer. She has studied up to 8th standard and she is asked to give healthcare facilities to people. Now the point is, does that confidence gap and skill gap that we were talking of in the previous slide is solved here? No, it isn't solved. The skill gap and the confidence gap still prevail. So the only way government could think of is to compulsorily send all the medicos to villages. And we ended up in strike. I do not know if it was right or wrong, but after this, there is no way that the government had to do. Now here, it might have come to any one of you by now, what if we could transfer a part of a doctor's mind into a health worker? Is it possible? Now in order to answer that, let us listen to an interesting story. Once upon a time, when I was not a doctor, I fell ill. I asked a doctor, what medicine should I take? He gave me paracetamol. I was okay within 2 days. The next day when my sister got ill, I again asked her to take paracetamol. She was not okay. She went to the same doctor. The doctor gave ciprofloxacin. She was fine. The next day, when another friend got ill, I gave ciprofloxacin. He was not okay. He went to the doctor again. The doctor gave chloroquine and he was fine. So what is the magic that doctor does? In order to understand how the mind of a doctor works, let's see this slide. There was fever in all the three cases. At one place he gave paracetamol, one place chloroquine, one place ciprofloxacin. How does he work? What is the magic behind this? It's nothing but it's the magic of a meticulous history taking. In the first case, he asked me if I had muscle pain. I said yes. He meant I had a viral fever and therefore paracetamol worked. In the next case, he asked if I had chills and rigors. I said yes. That means I had malaria and therefore chloroquine worked. And in the last case, there was a bowel problem, therefore typhoid, and therefore ciprofloxacin worked. So a kind of a crash course in medicine for you. Okay. Having said that, let us do an exercise, not medicine this time. Here's an equation. Will you solve it for me? X equals to? Yeah. Here's another. Y equals to? Plus or minus 3, right. Here's another. Z equals to? 4. I give one more. Oh, tough. What if I give you this with this? You can of course solve it, right? The point that I'm trying to make is sometimes the algorithms that we are talking of might really get complicated. In such a case, what do? We really needed to have a gadget in which we had burned a part of the doctor's mind and we came up with this. Ladies and gentlemen, Amrita is a handheld device which is very simple in structure. It has a battery, LCD screen and a board. I mean, Balaji is there, he designed it for me. I write protocols. We have an expert team which writes the protocols. We validate those protocols. To begin with, we are targeting infant mortality and maternal mortality. We burn into this gadget. One after the other, the questions come. The Asha, whoever handles it, has to feed in the answers. And basically, there's a printer, there's a scope for providing a printer in the gadget through which a bill comes out which writes down the diagnosis and treatment. So is it ever possible to do so? Probably we will get lost if we take medicine as a whole scenario. So how do we do that? We have begun with, I'm sorry, we have the infants and mothers to be targeted. Now, this happens to be a very small population to be targeted, so our effort is concentrated. Now, disease-wise, if you see, these are all the diseases which account for all the deaths caused in infants. The point that I'm trying to make is, apart from those 22%, all the rest of the 78% is because of 6 diseases: pneumonia, diarrhea, malaria, measles, HIV, and prenatal infections. So if you could address them with protocols, a great part of our burden is solved. So let's see how the gadget works. Say Fatima is a 2-month-old girl. She is having diarrhea for 13 days now and she looks unwell. Her mother gets worried. Her mother works on daily wages, so she hadn't have time to take her to the hospital. And now, after knowing that there is a device like this placed next to her lane with an Asha, she says, okay, I'll take my daughter there. The gadget asks general informations. The Asha feeds in the name, age and sex. Now, the processing that occurs is the age is less than 2 months. We got 2 protocols, one for children less than 2 months, one for 2 months to 5 years. Basing upon that, the next question comes, what is the complaint? You say fever, diarrhea, ear pain, anything? In this case, say diarrhea. The next question, was the child brought unconscious to you? You say no, which means diarrhea, no associated danger sign. The next question, does the child respond well when you clap? You say no, which means diarrhea, child is lethargic. Okay, next question, does the child have blood in stools? You say no, which means diarrhea, lethargic child, no dysentery. How long has the diarrhea been? you say 13, which is less than 14. According to my protocol, this should not be a severe dehydration case. The next question comes. Do the child's eye appear sunken? You say yes. Okay, some dehydration is likely. And then I ask to do a test wherein I say, pinch a fold of the skin on the side of the child's umbilicus and note what is the time it takes to regain its normal position. And you got to put a number in seconds. You say 3 seconds. I say diarrhea, lethargy with severe dehydration. And therefore the slips come out. Fatima, 2-month-old female, diarrhea with severe dehydration, therefore she needs immediate referral. On the way to the hospital, she needs to get frequent sips of ORS, continue breastfeeding, and keep the child close to the body over the, and cover the child with a towel so that hypothermia is prevented. So basically, what is it doing? What is the gadget doing? It is increasing the coverage. Because we are giving it to an ASHA, we don't depend upon a normal health worker anymore. So we have increased the coverage 4 times. What else? We are increasing the efficiency of the health worker, right? Because, I mean, you need not go through this whole protocol every time. Now, supposing you don't have diarrhea, I don't ask you questions about diarrhea, and so, you save time. It increases compliance. The same health worker can work on a tuberculosis control program, at the same time antenatal care, at the same time child survival and safe motherhood, anyway. And then it increases all this together, leads to an increase in years of life gained, and the gadget can also help in data collection and storage, the survey thing, which is really bad in our country. So basically, the gadget acts like a filter. In the upstream, it saves time for the people, for the patients. What else it does? It saves money. Downstream, it increases efficiency, it increases years of life gain, because we can really concentrate the effort and money on cases which need it the most. Later, the gadget can have a voice interface wherein an illiterate person can also use it. We have thought of introducing a GSM port wherein we can operate telemedicine when it comes up, and we can have kiosks placed in the urban centers wherein the gadget can be used, like in your college. So the community trial is about to start this March. National Rural Health Mission is looking at it with full interest. We have signed a MOU of 4.75 lakhs with the NRHM. Madam Vaidyanathan, who is an IAS officer, the Mission Director, National Rural Health Mission, is extending her full support. We have an expert team comprising of professors from my college, from the Community Medicine Department, people from Institute of Child Health, Institute of Pediatrics, RSRM, and Institute of Obstetrics and Gynecology. So this is my team. Balaji made the gadget for me. The other 3 people are from NIT Surathkal, and we won the social entrepreneurship event at IIM Ahmedabad. IIM Ahmedabad entrepreneurship cell is interested in us. Thank you, thank you, thank you. And excuse me, I didn't finish, sorry. Yeah, and probably will get incubated there. So before I end, I will remember 1947 when we made the tryst with destiny. Nehru said, it was the dream of one of the greatest men of our times, I mean hinting at Mahatma Gandhi, to wipe away every tear from every eye. It might be beyond us, but so long is our work not over, as long as there exist tears and suffering. So basically, I do not know how much we have succeeded, but on the eve of the 60th Republic Day, the President reinforces, we have promises to keep. It is we who have promises to keep. You must be thinking, why did I choose this Sin City theme, black and white and red? Because I thought I'll keep the colors, I'll save the colors. At the end, I will leave you with a picture of Amrita and colors of hope. Thank you.